across disciplines who aim to prevent cancer, develop better treatments, and help survivors live full, healthy lives. And she is here for our Frankly Speaking About Cancer, Living with Metastatic Breast Cancer presentation. Please join me in welcoming Dr. Mortimer.
So I want to make this about you guys and make sure that you get your questions answered about metastatic breast cancer. You know, I've been doing this for 35 years, and you know, the face of how we treat women with breast cancer has changed rather dramatically in that time. You know, get used to. I'm sorry, you can't hear me.
I'm having a hard time. You're a little closer.
Anyway, hold it. Can you hear it now?
Oh, that's better.
It has to be really up. Okay. So the treatment of metastatic breast cancer has changed a lot over the last probably 10 or 15 years, more than the years prior to that. And what I thought I'd do today is I'm just going to give you sort of a basic outline of how we treat metastatic breast cancer, and then I want to take your questions so I can answer the things that you all are concerned about. How many of you are on treatment right now? I'm guessing the majority. Okay. So you know, when we treat, okay, this is now on film. Grabbing my thing. So when we treat metastatic breast cancer, you know, the first thing that we need to do is to know the type of breast cancer. So, you know, most of the time, breast cancer doesn't present as metastatic disease. Only about 1 in 20 women who have metastatic breast cancer present with metastatic disease at the time of their initial diagnosis. For most people, it's metastases develop after a time period where you were treated for curative intent for early stage breast cancer. So when the tumor comes back, it's always critical that we biopsy the tumor, because as we treat breast cancer, and I suspect you guys are all pretty much expert at this by now, you know, the three markers that we need to know about are the estrogen and progesterone receptor, in which case people are treated with hormonal therapy, and the HER2 status, in which case people receive HER2 types of treatments like Herceptin and Perjeta and neratinib. And so it's critical that we biopsy the tumor, because cancers sometimes change over time. So sometimes a woman whose cancer is initially estrogen receptor positive, when it comes back in the liver and we biopsy it, it won't be estrogen receptor positive anymore. So it really is critical that we biopsy the tumor to know what the characteristics of that cancer are. And as time has gone on, we've come to realize that there's really value in biopsying the disease several times afterwards, because sometimes it will really change its character and go from being mostly estrogen positive to estrogen negative. And you know, even on occasion, a woman who has...
You might be able to fix it.
Okay.
Sorry to interrupt.
So a woman who has a HER2 negative breast cancer initially, sometimes about 20% of the time it can be HER2 positive, or vice versa. So doing a biopsy has taken on a lot of importance as we have more and more treatments to treat women with metastatic breast cancer. And sometimes what we do is to send the tumor off to look at gene testing on it, not the genes that you inherited from your parents, but the genes in the cancer that tell us what makes the cancer grow, because sometimes we can find drugs that we don't normally use for breast cancer that now we expect to work because of the mutation in the cancer that's developed either after treatment or at the time that you do the initial biopsy. So when we treat metastatic breast cancer, the first thing we do is hormone receptors and the HER2 status. And if you are hormone positive, estrogen and progesterone positive, the changes that have occurred over the last decades have been huge. In the last 5 to 7 years, we have this whole new class of drugs, the CDK4/6 inhibitors, and they're all on television. The Ibrance commercials where the woman has her new norm, which I suspect you all find kind of offensive.
Yes.
Yes, it is kind of, anyway. Those drugs are very, very important, because what they've done to normal hormone therapy that we've been using since, you know, really the 1940s, we've been using hormone therapy to treat breast cancer. But what these drugs do is they make the cancer more likely to shrink with hormone therapy. They make it twice as likely that it'll shrink, and they make the duration of that effect twice as long. And so those have been drugs just within the past within the past like 5 to 7 years that we have those drugs available. When women have hormone receptor positive breast cancer, the sort of natural course of the disease is that we put you in a remission with these hormone therapies and the Ibrance or the other two drugs, the abemaciclib or ribociclib. There are 3 drugs in that category, and they're all pretty much the same. And so what these drugs do is put you in a remission, and the sort of median time that people go into remission for is over 2 years. So that keeps the cancer under control for a couple years. When it stops working, we usually go to another hormonal therapy. And if that works, it'll work for another period of time, we go to another hormone therapy. So just changing the hormone environment, whether it's with drugs like Arimidex and Femara and Aromacin, or if it's with shots with the Faslodex, I suspect some of you have had Faslodex as shots in your buttocks. All these change the hormone environment so that it's hostile to the cancer and the cancer can't grow and then dies. Over time, what happens with estrogen-fed breast cancer is that it stops responding to hormone therapy. And when that happens, then we go to chemotherapy. If the cancer is estrogen negative and HER2 negative, the treatment is also with chemotherapy. And what chemotherapy can accomplish is can make people feel better for a long period of time, can shrink the cancer. And you know, there are as many as 4 to 5% of people who really don't seem to have their cancer come back. These women are few and far between, unfortunately, but there are women who get treated for metastatic breast cancer who never have it come back again. And then the last treatment is, of course, the HER2 therapy. So anybody here HER2 positive? Okay. So, you know, HER2 positive breast cancer is a very aggressive type of breast cancer. And okay.
Yeah, but I don't think your mic is
So HER2 positive breast cancer used to be considered, you know, the most aggressive. Wow. Okay. Now you're there. HER2 positive breast cancer used to be the more aggressive type of breast cancer. So women who had HER2 positive breast cancers were more likely to have cancer come back. When it came back fast. People died more often of HER2 positive breast cancer. But in the late 90s, the development of the drug Herceptin has totally revolutionized the way that this disease is treated and what the outcome of this disease is. So when when somebody has HER2 positive breast cancer, yes, we use chemotherapy, but we use all these HER2-directed treatments like Herceptin, Perjeta. We do chemotherapy with those 2 drugs at the start. And those drugs, we usually use the chemotherapy for 4 to 6 doses, and then we just keep you on the Herceptin and the Perjeta. And there are women who are in continued remission, again, for years on those drugs. When they stop working, when they stop working, there are other HER2 therapies like Cancycla, there are pills, Gabapentin, but HER2 positive breast cancer now sort of stage for stage and you know, size for size. Actually, people do better with HER2 positive breast cancer than other cancers now because these HER2 therapies are so incredibly effective. Yes.
You mentioned that first you do hormone therapy, and if it's not working, then you do chemo. But usually it's the opposite. They always do chemo and then they give you hormone therapy. I want to know if I didn't do chemo and I stopped to do hormone therapy, I am in a danger.
So the question is, what's the order of chemotherapy and hormone therapy? So when people are newly diagnosed with breast cancer and our goal is cure, we usually do chemotherapy first and then put people on hormonal therapy.
Yeah.
But once breast cancer comes back, if it comes back, the liver, the lungs, the bone, wherever, then our treatment, if the cancer is hormone fed, we always use hormonal therapy alone. Good questions. So there are a lot of different chemotherapy agents that are available. And you know, breast cancer right now is really, even when it's metastatic, and our goal, unfortunately, is not usually curative. Our goal is to keep it under control as long as possible. This has become really a chronic disease. There are a number of different chemotherapy drugs that we use, and whether the cancer starts out estrogen positive and then stops responding to hormones, or whether it's estrogen negative, most women with breast cancer actually have access to all of these chemotherapy drugs that are effective over time. And again, the goal is to keep the disease under control so that people can function as normally as possible. Question? Yeah.
With Kadcyla, TDM1, how much is the side effects of the chemo reduced?
Yeah.
I can't hear.
So I'll repeat it. Yeah.
She'll repeat.
Yeah.
So that's what and so versus getting straight chemo versus targeted with the Herceptin. I just want to know, is it as extreme, the devastating side effects on a body, as it would be just chemo by itself?
So the question is about the drug Kadcyla. So Kadcyla is a drug, is basically Herceptin with a bomb attached to it. So, the ideal drug is one that really only goes to the cancer and it doesn't affect the normal body. So what Kadcyla is the cancer that's HER2 positive. This is an antibody, Herceptin. It binds onto that cancer cell. And attached to the Herceptin is this poison maytansine. And therefore what happens is the Herceptin just takes the poison directly to the cancer cell. And so in theory there shouldn't be a lot of side effects to the normal body. And in fact that really is the case. So this particular drug in HER2 positive breast cancer is an incredibly active drug, and it doesn't have a whole lot of side effects. Some people can get a little nerve problem, some people can have their blood counts drop, but it doesn't usually make your hair fall out. People don't usually have the fatigue that you have on other types of chemotherapy. And this really is a model for other types of chemotherapy. So there is a drug that's now in study right now called sacituzumab. So this is a drug that's very similar to Herceptin, but the target is different. So it identifies a different target in cancer cells, and it delivers a chemotherapy drug directly to the cancer cell as well. So these antibody drug conjugates, you identify a target, you create an antibody that binds onto that target, and that antibody delivers with it a chemotherapy or a toxin that will kill the cancer without actually having the antibody take it to normal tissues. And so this really is an important avenue of research that really is truly targeted therapy, where you deliver the cancer-killing drug directly to the cancer itself, and therefore you don't have the other side effects of mouth sores and hair loss and nail changes and all of that.
How do you spell that?
Sacituzumab, it's SASITIZUMAB.
And it's obviously part of the Herceptin family, so...
And it's not, it's actually not binding to HER2. This is not a HER2 drug.
What
This
does
is
it
a
bind
drug,
to?
it binds to a specific protein on triple-negative breast cancers and HER2 and hormone receptor-positive breast cancers. And in both those diseases, it turns out to be very active. It was first tested in triple-negative breast cancer. Anybody hear of triple-negative breast cancer? So estrogen negative, progesterone negative, and HER2 negative. And because there are no targets like estrogen receptor or HER2, triple-negative breast cancer is really only treated with chemotherapy. And in this case, the sacituzumab actually targets one of the proteins that helps it grow.
What's the name of the protein?
It's a strop protein. It's STO.
STO?
Yeah.
STRO? STO.
STO.
Thank you so much.
Yes.
Hi. So I have lobular metastatic ER-positive breast cancer. I'm on my second line. I'm taking Faslodex and Ibrance. The Ibrance, 125, put me in the hospital right away after 10 days. So I went down to 75. I didn't want to try the 100. Do you have patients on 75? I know I'm an advocate. I was at San Antonio, so but I always, that's the big picture. I never get to ask my own stuff, so this is a good opportunity. My question is, some doctors don't know if 75 is good enough. I know there was a paper that said dose reductions in 75 or 100 were the same. There was no difference. So I'm just wondering, with your patients and your practice, what do you tell patients if they can't,
So I'm going to focus on the question is about lobular breast cancer. So lobular breast cancer is somewhat different than cancer that starts in the ducts. So if you think about the breast as sort of having branches and leaves, the lobules are the leaves and the branches are the ducts, and most breast cancer actually starts in the ducts. Lobular breast cancer it behaves very differently than duct cancer. It's usually estrogen fed, and it just can sort of spread in funny ways. It's often missed on mammogram. So when you see women who have a cancer that was missed on mammography, a lot of the time it's because it's a lobular breast cancer, not a ductal cancer. I don't know if that was your case, okay?
Yeah, yes.
And often it's bilateral, it's in both breasts. And it can be a very slow-growing disease. It usually does respond to hormones. The question was, and the woman on the ad on the television who has her new normal doesn't talk about dose, but the starting dose for the Ibrance, which makes the hormone more effective, the starting dose is 125 milligrams a day. And the usual side effects of Ibrance are that it can drop your white count, and it can cause mouth sores, and people feel fatigue. Those are probably the most common things that people experience. And what the right dose is, and this is probably a question not just about Ibrance, but for everything we use. Whenever a drug is sort of approved for use especially in cancer, we give the maximum tolerated dose. So the maximum tolerated dose is determined by how high the dose of the drug can get before somebody has like significant side effects. Because a lot of people have significant side effects. As a patient, you don't care about the maximum tolerated dose. You care about the minimum effective dose.
Yes.
But unfortunately, that's not how drug development happens, and we talked about that for a long time. So what's the right dose of Ibrance, or for that matter, any chemotherapy drug? Everybody handles drugs differently, and you have to activate the drug, you have to get rid of it in your system, and everybody's liver and kidneys don't necessarily get rid of drugs the same way, and so a drug that may be given at a dose of 125 milligrams in you may cause an awful lot of white cell depression, whereas other people can tolerate it without problem. And it's not necessarily related to age, it's probably more individual, like how your body handles the drugs. So the right dose of Ibrance seems to be the dose that drops your blood count to a level that's low but not too low. And so sometimes, I have a lot of people around 75 milligrams a day, so that seems to be a lot lower than 125 milligrams, but still their blood counts were low as a result of it. And there are some studies that show that women whose blood counts drop at all are the folks who benefit most from Ibrance. So it's not so much the dose, but the impact it has on your counts that seems to be most important.
I'm sorry, to follow up, can you address the mouth sores and also the hot flashes from the Faslodex and what you think is the best kind of solutions to those things?
Okay, so mouth sores with Ibrance are sort of weird.
I get them.
And they're tiny. They're usually these tiny little ulcers that come and go through your big.
Okay. I get them right away as soon as I start it.
Wow.
Yeah.
So you're obviously at a good dose and it's doing stuff.
Well, my counts are like 1.7, 1.5, something like that.
Yeah, so your counts are dropped enough. So,
Yeah.
so the mouth soreness, the only time we ever stop the drugs that cause mouth soreness is if they interfere with your ability to eat. And if they don't, then we just sort of give you lots of things that make it feel better. The Ibrance ulcers are usually pretty weird. They're very, very tiny in most people. They're usually, on the tongue or the inside of the mouth, and they come and go throughout the month. It's like usually when people get mouth sores, it's within the first 5 days of starting a drug, and they usually last for 5 days. But because you're taking Ibrance continuously, they kind of come and go throughout the cycle. It's kind of weird. And when they initially developed this drug, they didn't appreciate that mouth sores were a side effect. And I think that's a really, really important thing to note, because drugs right now, in an effort to get patients with diseases like breast cancer access to drugs quickly, those drugs are brought to market a lot sooner than we have the ability to know all the side effects. So if you look at a drug that comes to market, like over the next 7 years after a drug has been on the market, more than 50% of side effects are identified. So things like mouth sores with Ibrance really weren't appreciated until the drug had been approved and been used for a long period of time. The other question was about hot flashes with Faslodex. How many of you folks have hot flashes? Yes. Yeah. There's some things you can count on. Yeah. You know, so hot flashes are a common problem. Obviously, they're common for older women in general who go through menopause, but they're especially common in women who have breast cancer because when we give you treatment, if you're before menopause, we abruptly put you into menopause. And not that menopause is a joy in its natural aging state, but when you abruptly go into menopause, it seems like the side effects are much worse. The menopausal side effects are much worse than when you sort of slowly age into menopause. So the kinds of things that we do to manage hot flashes, you know, if you can tolerate your hot flashes, then that's great, okay? But a lot of people find them absolutely unbearable, and they wake you up in the middle of the night, and they keep you awake, and then you have a chill, and the covers are on and the covers are off. And in terms of things that people do for hot flashes, there are a lot of studies that have been done trying to look at how best to make, especially women with breast cancer, comfortable with hot flashes. You know, there is some data that if you take vitamin E at a dose of 900 milligrams a day, that you maybe decrease the severity of a hot flash a little bit. So vitamin E it's a positive study, but it's not like a meaningful result. Yes, they're a little bit less severe. The drugs that most often work for hot flashes are a whole group of drugs. One is the Gabapentin or Neurontin, and like a similar drug is always on the television ads is Lyrica. And what Gabapentin or Neurontin does is it really will help people cut the edge off of hot flashes. It works in about 40 to 50% of people. So nothing that we do to treat hot flashes works in 100% of people, but usually we can get people a little bit more comfortable. So gabapentin is a drug, and the way that we give this is I don't know anybody who's on Neurontin or gabapentin, okay? So usually when you take it, people use it for nerve problems usually, and we have you take it 3 times a day. The main side effect of gabapentin is it makes people sleepy. And so most of the time when people are having hot flashes, it's at night. That's what's the most disruptive to your quality of life. So the studies that were done using gabapentin to manage hot flashes used a dose of 300, 600, and 900 milligrams at night only. And it turned out that the number of patients who got the most benefit was at the dose of 900 milligrams. So just one dose at night. And it sort of accomplishes making you sleepy, and for people it works, and it's really pretty magical that the hot flashes go away. They're not magical.
The long-acting one, the Gralise, because I had a nerve problem, and I started with that.
Yes.
And I was on 1200, which throughout the whole day, and it stopped kind of working. So I'm upping it, and I went up to 1500 right now, and it seems to be helping.
Yeah, so the right dose is really not for sure known because the study really did 300, 600, 900, and I've had people who go much higher than that to get comfort. We don't usually use the long-acting Neurontin gabapentin because it's so expensive. Most insurance won't let you take it, so that's why we don't have a lot of experience using it for just that side effect alone. You know, the other group of drugs that work for these menopausal symptoms are the antidepressants. So the reason that people have hot flashes is that you lose estrogen in the very base of your brain, the brain stem part. So it sits like this. Here's your neck, and here's the base of your brain, and then the rest of your brain comes off the top. Right, a very, very narrow area in the brain is where a lot of action happens, managing your temperature, your ability to sleep, your mood, and libido. And all 4 of those are sitting in this very, very tiny area of the brain. And when they work, they need serotonin, the protein, the amino acid serotonin, to make them effective, to function normally. What happens when you go through menopause or when you get these drugs where your estrogen is lowered is there's a low estrogen, and basically what changes in the temperature regulation is normally you can regulate your temperature between a wide distance. What happens when you lose your estrogen is it goes much narrower. So whereas before you could go out and cold and get hot and none of that bothered you, now you can't regulate it anymore, and so it takes very little heat to make you have a hot flash. And also, as you can also anticipate is when people go through menopause and you lose your estrogen, it's not just about hot flashes. People have trouble sleeping, people have trouble with mood, and people have a loss of libido. And so one of the ways to sort of attack this part of the brain, because you need serotonin to function, is to give you drugs like the antidepressants that make the serotonin level in your brain higher. So drugs like Prozac and Paxil and Effexor, all of these drugs will raise the serotonin level in the brain. They're especially good in people with helping with hot flashes. A lot of people who have irritability, I don't know if you have this problem where in menopause where you just like want to very short fuse. This is very typical when people are on hormone therapy, and when people go through menopause, you just can't keep it in anymore. Your emotional control is dysregulated. Sleep is a problem, and so these drugs really are especially good for hot flash, for people who are having that irritability. I mean, I had a woman one time who in the midst of having like sort of a menopausal rage, like ran her car into somebody in front of her. So I mean, it's sort of an interesting story to tell. But I mean, this person, I mean, this was not her normal self, and so having that sort of loss of control and emotionality is really part of having low hormone levels. And so for women who have that irritability and problem sleeping and hot flashes, preferentially we often use the antidepressants rather than using Gabapentin. Unfortunately, these don't do anything to libido, but they are effective in some people, and again, not all people, for hot flashes. The people I often put on antidepressants rather than Gabapentin are people who do have that irritability that comes with menopause or with hormone depletion. And then you sort of get a twofer. They usually stop being so irritable, and the hot flashes may go away as well.
Why do you think it's better than the Gabapentin?
Because in people who have it's better than Gabapentin, or it's probably a better drug to choose in people who have that emotional sort of irritability. I mean, does anybody have that sort of weepiness and stuff? I have a patient who was sitting at the dinner table sobbing over her cat's death, and the cat was alive. Oh. So it's that sort of irrational. I mean, she knew totally this made no sense, but it doesn't mean you can help it. So that sort of over emotionality that happens, which is part of hormone lack. Those are the folks that most benefit from the antidepressants. The fascinating thing about using these antidepressants for menopause symptoms, and we use them in help people without breast cancer to manage menopause symptoms. But if you're using an antidepressant, it usually takes you 3 to 4 weeks before you get the antidepressant effect. In women who are having hot flashes, you don't need a very high dose, and it usually works within about 7 to 10 days that they start to feel better. So it seems to be by a different mechanism than people who are truly on these drugs for true depression. Yes?
My question is, somebody have a breast cancer and doesn't do the chemo, have a more chance that the comeback, the cancer come back more than the other people that they do chemo?
So you're talking about, so the question is, should people have chemotherapy when they're newly diagnosed with breast cancer? Does that actually mean when they're first diagnosed to have cancer in the breast?
Yeah.
Yeah, so when we have a woman with a newly diagnosed breast cancer, the way that we treat breast cancer, as you guys all know, is you treat the whole breast, and you treat the risk of cancer cells being in your bloodstream. So the whole breast is treated either with a lumpectomy and radiation or a mastectomy. That way the whole breast is treated. And then the question of who needs to get drugs, hormones, and chemotherapy, who needs them to mop up microscopic disease? Yeah. Because it took us years to demonstrate that people, even with clean lymph nodes and small tumors, have a risk of getting cancer showing up within the next 3 to 5 years kind of thing. So how we determine who should get chemotherapy, if their estrogen receptor is negative and their hormone HER2 is negative, those women in general get chemotherapy. If the cancer is estrogen fed, is hormone receptor positive, we usually send the cancer off for an oncotype test. This is a particular test that looks at the genes of your cancer to tell us how aggressive it is. And if that number is above a certain level, then chemotherapy and hormones are necessary. If it's below a certain level that tells us this is not an aggressive cancer, then we just treat it with hormone therapy. And the third group of women are the women with HER2-positive breast cancer, and those women we invariably use Herceptin with chemotherapy in those women for a period of time. So in a new diagnosis of breast cancer, there's a lot of thought and that's based on studies that have looked at the benefit of chemo or not, and doing these special molecular markers, the Oncotype
So
test.
hormone therapy is necessary for everybody.
Everybody whose estrogen or progesterone receptor is positive. If the cancer is estrogen negative and progesterone negative and HER2 negative, no hormone therapy.
Okay.
Yeah. Other questions? Yes.
I have a lot of questions, so I don't want to take over, but what kind of scans do you recommend for people with bone-only disease, and how often?
Okay. This is a really hard question. How often do we do scans in people with bone-only disease? So in estrogen-fed breast cancer, it has a very weird pattern of metastasis that often can be only in the bones. And the reason why and how it happens is presumably those cancer cells circulate in your blood. They get into the marrow of the bone, and they take root within the marrow, and over time they grow big enough to cause you a symptom, a fracture or some pain, and then the cancer gets identified. You know, for Olivia Newton-John, who took 20 years for her tumor in her spine to show up, it's hard to understand what happened in those 20 years. But sometimes it can be a very long course, and when it's only in the bones, the problem is it's very difficult to follow. So if you have a lymph node in your neck and we give you treatment, that lymph node shrinks and we know your cancer is responding. The problem with looking at tumors in the bone is that the cancer sort of destroys the bone, and then when it shrinks as a result of chemotherapy or hormone therapy, there's a lot of new bone that forms. So what bone scans measure, what a bone scan measures when you do a bone scan, is new bone forming. So if we start somebody on a new therapy today, and their bone scan's abnormal, there's areas of the bone scan that are abnormal, and then we do a bone scan again in 2 months, sometimes the bone scan looks worse, and it doesn't look worse because the cancer's growing, it looks worse because we've killed the cancer, and now what we're seeing is the new bone forming, and that makes the bone scan look at more abnormal than it did before. Does that make sense? And so as we're laying down new bone, that makes the bone scan abnormal, and so bone scans are really hard to follow for people who only have bone-only disease. Sometimes PET scans are more effective. PET scans are, I'm sure you all had PET scans, or a lot of you had PET scans. PET scans use glucose, and the thing about glucose in cancer is that glucose is taken up by cancers more rapidly because they're growing faster, but in cancer cells they get trapped. So not only does it take up more glucose, but it traps the glucose, and so what the PET scan does is it's labeling glucose so that if something's taking up glucose faster and holding it inside, we can see it. So it's somewhat more sensitive at finding cancers than a regular CAT scan may be. And so in answer to your question, how often you do tests sort of addresses how do we know whether the treatment is working. And if somebody has lymph nodes or tumor on the skin, it's easier to know what's going on. You can feel the lumps go down and the skin get better. For people who have like tumor in the liver or the lungs or the bones, then we need to do other tests. And a PET scan may be more sensitive at finding disease in the bone in people who only have disease in the bone than a bone scan or a CAT scan. The other thing is measuring tumor markers. So how many of you had your tumor markers measured? Yes. So tumor markers are what we measure when we measure a tumor marker is a protein that's made by the cancer cells, and we measure it in the blood. And for some people, it's very reliable. When the cancer comes back, it's there, it's elevated. When the cancer shrinks, it goes down. When it stops responding, it goes up again. But it's not super reliable in everybody. So sometimes people can have their up and down tumor markers, even though their CAT scans show that their liver tumors have completely gone away. So for some people, they're not reliable. For other people, they are reliable. And if it turns out that measuring a tumor marker in you is reliable, then tumor markers are very helpful and may prevent the need for doing x-rays on you all the time. unfortunately, like prostate cancer, we use the PSA as a very effective marker in prostate cancer. Men who have prostate cancer, their PSA gets checked, and when it comes back up, you know that their cancer is back. And we do it in men who've been treated curatively for prostate cancer. But in women who've had surgery and chemotherapy and hormone therapy for a new diagnosis of breast cancer, we don't follow those markers because they can be up when there's nothing and normal when there's a lot of disease. So unfortunately, they're not good to identify early recurrence of breast cancer, but they can be helpful in following disease and may prevent the need to do all these other x-rays. Yes.
I'm right there with you. On the Faslodex shots, if you're really sensitive, which unfortunately I am, to all medication, what do you advise to make it less painful? I don't do well when I have a big onslaught of medication all at once. Like infusions have to be slowed down tremendously, and so I'm very scared of even getting a half dose of the Faslodex. And I don't. Do you advise getting Benadryl and Tylenol before? What do you advise?
So the question is about how to minimize the discomfort associated with Faslodex. So how many of you know about Faslodex as a shot and gotten it? Yes. So Faslodex is a hormone therapy or anti-hormone therapy, and it's an incredibly important drug. It has fewer side effects than a lot of the hormone pills that we use. Like hot flashes are usually less than with drugs like Arimidex, Aromasin, Femara, or Tamoxifen. But Faslodex is a shot, and unfortunately that's its downside. So when we first developed Faslodex, and this is like 1989, we started it with an injection in the buttocks, which it still is, but the nursing standards for giving an injection were, like, I think it was 3 cc, so 3/5 of a teaspoon. The dose of Faslodex that we give is 5 cc's. It's a full teaspoon of liquid in order to get it in there. And so, like, all our nursing regulations sort of had to be changed to accommodate the fact that we put a lot of fluid in your buttocks when you get a Faslodex shot. And then further add to it that it turns out that if we sort of load you, if we give you an extra dose for 3 times before you go to the monthly dose, that you get a level of the drug in your system that is high enough that then you can stay on the once a month shot. So, but that means that you get a shot in each buttocks, every 2 weeks, 3 times, and then go to shot in each buttocks every other time. So this is, every month. So this actually is a drug that's major side effect is actually the fact that you get a shot in the butt, and it's a big one. So the people who get the least side effects associated with them are people with a lot of flesh injected in. That's a first plus. But taking drugs like Claritin or Benadryl, a lot of people notice that helps. And also, the nurses warm it before they inject it. And that helps, because if you put it in cold, it really hurts and burns. And there are some people who always get this sort of reaction to it, that they get sort of hot and feel uncomfortable, cough, and usually it doesn't last for very long. And I can't tell you why that happens, and that's a side effect that, gosh, we've only recognized in the last 5 years, and this is a drug that was developed in the late 1980s. But yeah, taking an antihistamine, yes.
I've been on this drug for 7 years. And how is it determined how long a patient stays on it?
Okay, so the question is how long you keep somebody on a drug. So in the case of hormone therapy, we keep it going as long as there's no cancer coming back, we keep it going. And yes. I think we all worry, are there people who may never have any cancer come back after 7 years on the drug? We don't have any data to tell us to stop it, and so I think we're so worried. I have a lady who in 1998 was started on a hormone pill, Megace, which we used to use years ago after Tamoxifen. She's been on this drug now for 21 years, and I'm scared to take her off it because she had tumor in her bone. We documented it. There's no question that her cancer came back, and so I think we're really afraid to stop it. The counterpart of that is also the HER2 people on Herceptin. We put them into remission, get the cancer under control, and then we keep you on Herceptin with or without Perjeta, and we have people on those drugs for literally years and years, and we don't know if we stop it, will the cancer start to grow again? That certainly is our fear, and we have very little data to know what happens. So, so as a result, we...
How come for tamoxifen they say 5 years, 10 years, they always say tamoxifen
So
have a certain...
the question is how long we recommend tamoxifen for people, and that's in newly diagnosed breast cancer. So right now the recommendation is still 10 years. 10 years is better than 5 years, yeah. There are fewer cancer recurrences and deaths, yes.
How long do you take the Zoladex for?
This is a really tough one here. So how long do we take Zoladex for? So Zoladex is a drug that we use for men with prostate cancer. We use it for young women with breast cancer. And we put people on Zoladex when we want to shut off their ovaries. And so if you have metastatic breast cancer and you're on a hormone, either we take out the ovaries or we put you on drugs like Zoladex so that the ovaries aren't making any estrogen. So if you are before menopause, 80% of your estrogen comes from your ovaries. And if you have breast cancer that grows with estrogen, the last thing we want you to do is to have your ovaries functioning. So either we take them out or we put you on drugs like Zoladex or Lupron that shut the ovaries down. And we keep you on that unless the cancer starts to grow again. We keep you on that indefinitely. Or at some point, if you've been on it for years, we stop it and then check your hormone function and see if you've now gone into menopause. But we use it to keep you in menopause, and if you're on treatment with drugs that we need you to be in menopause for, we keep it going kind of indefinitely or until we recheck your hormones. That could be years, yes. Yes?
Two quick questions about drugs. Then Fascidex, can that create, I heard a side effect of a cough, but can it create a chronic cough?
So the question is, can Fascidex cause a chronic cough? Not that I'm aware of, because usually the people who get the cough or who realize the cough are the nurses doing the injection. It usually happens like right around the time of the injection. I don't know if you've ever had that, but it happens right as you're getting the injection that people get cough. It doesn't last. It does not continue on, no.
Okay, and the other question is in regard to Arimidex. How far out now are the studies on Arimidex? It used to be a 5-year drug.
Yeah.
I took it for 7 years, and I've been off of it for maybe two years now.
Okay. So in women who have a new diagnosis of breast cancer, we just talked about taking tamoxifen for 10 years is preferable to 5 years. The other group of drugs that we usually use in women who have breast cancer diagnosed after menopause, when we put you on a hormone, we put you on these aromatase inhibitors, Arimidex, Femara, Aromasin, and they're all kind of the same. So because tamoxifen was better 10 years versus 5 years, we did studies looking at Arimidex or these other drugs, 5 years versus 7.5 years, or 5 years versus 10 years. And it doesn't look like there's an advantage to taking it for more than 5 years, which is not what we expected since tamoxifen is better. So, why could that be? Well, one of the reasons we think is that tamoxifen estrogen effects on your normal body. And the benefit of that is that women who take tamoxifen are less likely to have heart disease, less likely to have heart failure. It increases your bone density, and it lowers your lipid profile, so it improves your cholesterol. And so those are sort of obviously good effects. Whereas Arimidex and Aromasin and Femara, those drugs can increase your cholesterol, it can decrease your bone density, and it can make your lipids go up. So, maybe the good effects of tamoxifen for 10 years are related to the good effects being on your normal body as well as their effects on the cancer, whereas Arimidex, the sort of negative effects on your normal body, just sort of, yeah.
So if somebody had a tamoxifen and didn't work out as a side effect, and they stop it, and then you can start it again?
Yes, you can start again and see if, you can. Yes?
Yes, could you tell me more about capecitabine?
Oh, so we're going to talk about capecitabine. So, are people who's on capecitabine or Xeloda? Okay. So this is a really important drug in treating breast cancer. So Xeloda is a pill. It's really the only chemo pill that we use in metastatic breast cancer. And it's an interesting drug because it's sort of, by itself, it has to be picked up by the tumor cell and activated. So there are usually less side effects with capecitabine, with Xeloda, than with some of the other drugs. The way that chemotherapy works is it works on cells that are actively dividing. I mean, it's a little simplistic, but when cells are dividing is when the chemotherapy works. When you have a very slow-growing cancer like estrogen-fed breast cancers, which tend to be sort of slow-growing, even if they stop responding to hormones, they're still sort of slower growing. And if you give a whopping dose of an aggressive chemo drug, and those cells are not dividing, you're not killing very much of the cancer. So the nice thing about capecitabine is you take it every day, twice a day for 2 weeks, and then you're off for a week. So in theory, if you have a slow-growing cancer, you're more likely to have the division happen while you're taking the pill. So it's a very good drug in women with sort of slow-growing indolent types of breast cancer. The side effects of capecitabine are kind of weird. So when you start it, we always tell people you can get diarrhea or mouth soreness, it can drop your blood counts, those kinds of things can happen. But mostly what happens is after you've been on the drug for like 3 or 4 months, people get red hands and dry hands and sometimes even like cracks and blisters.
Yes.
Yeah.
And it can be pretty uncomfortable. And the way that we manage that, and this sort of goes back to how we all manage our drugs, is that sometimes we give it a week on and a week off. Sometimes we lower the dose, sometimes it's 2 weeks on and 2 weeks off, but we sort of modify it to your symptoms and how that your hands and feet are feeling.
He gave me some kind of with steroid cream.
Yeah, so that can, I guess, happen for some people. Mostly it's drug related, and the more drug you're on, the more likely it is to happen. So it's rare that it happens in the first month that you take the drug or even the second month. It seems to sort of accumulate, and by the 3rd and 4th month, most people have red palms and blisters in some cases. And then we just lower the dose or give you more time off to heal. And it's no less effective when we lower the dose and change the schedule from either every other week or 2 weeks on and 2 weeks off. In general, efficacy of treatment is sort of related to the amount of side effects that people get. And that doesn't hold for every disease or every drug, but you can only treat people as hard as your normal body will allow us, and so we do need to change the dose. And with capecitabine, we're always changing the dose and giving you more time off, because the longer you're on it, the harder it is to tolerate it. Yeah.
But the tamoxifen, they say that 1% has a chance when you use it, you get uterus cancer. What's good? They fix our breast and then they make it uterus cancer?
Well, so the question is about uterine cancer with tamoxifen, and it's roughly 1 or 2 in 100 women who have breast cancer who take tamoxifen will develop cancer of the uterus. I mean, almost half the population by the time you're at menopause will have had a hysterectomy, so that already takes that group of women off the table. But usually when people get cancer of the uterus on tamoxifen, it's usually found because you have vaginal bleeding. And if you're after menopause and you're having a period, there's something's not right. Tamoxifen can not only cause cancer of the uterus, but sometimes it causes polyps, and that can make you bleed as well. It's not a reason not to take the drug, because tamoxifen is a really important drug and a very effective drug, but it just means we need people to pay attention, and if you have a period, we need you to immediately see.
Very bad side effects.
Yeah.
Very bad side effects.
Yeah, and the other thing that can happen with tamoxifen, and this is again, just like people who get cancer of the uterus have high estrogen levels, and this goes back to tamoxifen having sort of estrogen effects on normal tissues. It can cause cancer of the uterus, and just like birth control pills where people can get blood clots, women on tamoxifen can also get blood clots. Neither cancer of the uterus nor blood clots usually happen in women who are under the age of 55. It certainly can. But it's usually older women that get these side effects, not the younger women. And usually we use this drug in premenopausal women. Yeah.
They call these the golden years.
Yeah.
It's really something. I just going back to Arimidex. What would I know? Some of the side effects would those side effects linger on into aging? I mean, like neuropathy and bone pain and.
So, the question is about what the long-term side effects of Arimidex are. And usually with all these hormonal therapies, when you're on them is when you have the side effects, and when you stop them, the side effects that were due to the drug really do go away. The problem is, we spend most of managing women with breast cancer. There's so much about menopause that's involved in this. So, You know, as women go into natural menopause, there are bone aches that happen. And like there was a very, very large study done in this country where women who went into menopause, half of them got hormone replacement, the other half didn't. Well, it turns out that the women who didn't get hormone replacement had a lot more joint and bone aching than the women who were on hormone replacement. And then there are some studies in Japanese women that women who have this menopausal aching, when they get estrogen, the aching goes away. So we don't really understand that. Like, how many of you have had aching from like Arimidex or Femara? Yeah, it's pretty miserable. You know, people wake up. They always just talk about women will do this to you. That they get up in the morning, their hands feel really tight, and as the day goes on, it gets better. When we do MRIs of the hands of women who have this problem, it turns out what we see is fluid in between the tendon spaces. So you wake up and you have this fluid, and as the day goes on and you move your hands, they get better because the fluid presumably is being squeezed out. But that's just the hands. You know, a lot of times people will get on the floor to pick something up and can't get up anymore because it's just this weird aching in the knees and the hips. And if that happens, we need to find a different drug. But when you stop the drug, the side effects go away. So the point being that sometimes it's really hard to tell the difference between what's sort of normal aging menopause symptoms from we induce menopause with all these drugs, but then when you stop them, you don't know what was going to happen naturally and what was from the drug. But the drugs are long gone, and the side effects from the drug per se should be gone.
Yeah, I agree with that last statement, because often I find myself, you know, talking with or inside, you know, comparing, you know, would I be feeling this way, you know, without going through cancer? You know, is this a natural part of aging? You know, and things like that.
Yeah,
so.
it really is very difficult to know what's natural aging from you know, the results of treatment and so on. But the side effects of being on a hormone really do go away when you're off it. It's always disappointing me when I have somebody who I stopped their Arimidex after 5 years, and then I say, and how do you feel? And they say, I still ache, and it's kind of like, okay, well, it wasn't the drug then, you know, it's just an aging menopausal things, yes. Yes.
To switch to a whole different subject about this, I know there's a lot of progress that's been made in immunotherapies, not quite yet for HER2, and what are your thoughts about, the first part is, you know, what are your hopes for immunotherapy coming up? And the second part is, what are your thoughts about the superviruses mutating in the cancer cells, being in the nuclei, therefore they're the drivers. And if they're not dealt with as the root cause of breast cancer or other cancers, and we're just constantly dealing with the proteins around the cancer cells, why is that not? I know there's research on HPV at the core of breast cancer, 40% of women. There's MMTV that's been proven in studies. So I really want to know why that's not being looked at.
Yeah, so the question is, so the second question was about viruses and their cause in breast cancer. And there is an MMTV virus, a mouse mammary tumor virus, that in third world countries does seem to cause breast cancer. In this country, it's been harder to establish that, and that's why it hasn't been a real focus of research. It's been hard to demonstrate that viruses contribute much to the growth of breast cancer in sort of urban women who in industrialized countries. That does not seem to be the major mechanism. We think the major reason why urban women in industrialized countries get breast cancer more often is because of, you know, having hormones functioning for longer. So delaying having children till after the age of 30, not having a lot of children, you having, you know, we now menstruate for longer, you start your periods early. So the longer you have uninterrupted menstrual periods, that's the highest risk for breast cancer. And women in industrialized countries just, they don't have kids at age 16, which really is protected for breast cancer. They wait until after 30, which does increase the risk of breast cancer. So the virus issue has been harder to establish in industrialized cities in women. The question about immunotherapy is just an enormous question. So we have to go back and talk about immunotherapy in breast cancer, because the new kind of immunotherapy is not particularly, we haven't figured that out yet, and I'll talk about that more, but never lose sight of the fact that one of the most important drugs that was developed to treat breast cancer, Herceptin, is an immunotherapy. It binds onto that HER2, it shuts off that HER2 so it can't divide. But actually what it also does is it makes your own body's immunity improve as well. So it has sort of two effects. Yes, it shuts down the cancer cell, but it beefs up your own immunity. So these drugs for HER2 positive breast cancer really are immunotherapies. You know, unfortunately, only 15% of all breast cancer is HER2 positive, so only 15% of people get the benefit of those drugs. But all the immunotherapy that like are on the billboards and the cigarettes, the small cell, the non-small cell lung cancer cures and the melanoma, those sorts of drugs have not been very effective in breast cancer. And when we look at women who are estrogen negative, progesterone negative, HER2 negative, the triple negative breast cancer, the more aggressive types of breast cancer, only about 18% of women will actually have their tumors shrink as a result of the immunotherapy that we see advertised in magazines and on television. So why is that? Is breast cancer not an immunologic disease, or have we just not figured out how to make those drugs work? And presumably it's the latter. Because there is some data that there are immune cells that come to the cancer after you start, for example, Ibrance and a hormone. So maybe we just haven't figured out how to get it to work optimally, and we certainly are doing that. We have a study at City of Hope in women with breast cancer that's HER2 positive that's spread to the brain, and that's a different type of immunotherapy where we take your own body's T cells that help to kill cancer and we engineer them to make them attack the cancer specifically. And in women who have tumor in the brain from their HER2 positive breast cancer who don't have other treatments, we actually have a study injecting these in the brain to try and see if we can stimulate that immunity in the brain to kill those cancer cells. And there are lots of different ways of kind of harnessing the immune system to try and make it more effective. But in breast cancer, other than Herceptin and the HER2 drugs, we really haven't quite mastered that yet. But yeah.
Can you talk a little bit more? You actually brought it up, but about how viruses affect cancer cells. I was thinking when that was being discussed, my sister, we have a lot of cancer in our female side of the family, and unfortunately my daughter has, knock on wood, no cancer, and we don't have the BRCA, but on her dad's side as well, a lot of cancer. Now, my sister had a few years back discovered that some HPV, and then she last year was diagnosed with breast cancer. Stage 1, she found it. How does that virus, and it also leads me to your question about what is cancer? Is it a virus? Is it chronic? Is it, I mean, what, I don't kind of get
yeah,
it.
So getting back to the yes, I would love to be put out of business as well. Yes,
I mean,
yeah.
really.
So first of all, human papillomavirus has really been shown to cause cancers of the cervix and the head and neck region and the penis, so, and the anus, so all 4 of those areas. It's a particular cell that gets abnormal, the squamous cell, and that's just sort of the skin-like outside line. So for that type of cancer, there's no question that having that at certain not all viruses, because people frequently have HPV. I mean, as you get older and have had, you know, sexual encounters with individuals who are HPV, it's pretty hard to be HPV negative. But there are certain strains of HPV that are more likely to cause cancer of the cervix than others, and so those subtypes are the ones that we have a vaccine against them. And so, you know, if we vaccinate, you know, boys and girls before they're sexually active, the presumption is we're going to obliterate cervical cancer, penile cancer, anal cancer, and some head and neck cancers. So that unquestionably is causative. The virus is an important part of causing cancer. What cancer generally is believed to be, these are your normal cells. So these are normal cells that your breast have that line the ducts, and that for whatever reason they become abnormal, they mutate, and instead of behaving normally cells grow and they die, and they grow and they die, and that's just normal, repair of tissues. But what happens when they have this, whatever stimulates this somatic mutation that happens, is that the cell then grows, divides, but doesn't die. And so it's this like perpetual growth of the cell and gets bigger and more abnormal looking and so on. So it actually, only in pregnancy and cancer do you allow something to grow in you without rejecting it, So I mean, and not to compare cancer with pregnancy, but your body's immune system is changed in pregnancy so that you keep the baby, and for whatever reasons, your body doesn't reject cancer when it starts to grow either. So it's sort of a weird. We don't totally understand this. I think the important thing that you brought up though was about family history, and initially we thought, well, about 1 out of 20 women who have breast cancer have a genetic predisposition. So that means that your genes, whether they're genes you inherited from your mom or dad, or genes that mutated after you were conceived, that they predispose you to cancer. What these genes do is they help repair DNA. So getting back to what causes cancer, this haywire stuff is growing. These cells out of your normal breasts start to grow and they don't stop. Well, normally you have genes that oversee that repair that so that you can't have an abnormal cell grow. It dies. But women who don't have these repair mechanisms, and they're genetically, they're inherited, those are the folks who are more likely to get breast cancer. So the BRCA1 and BRCA2, there are a whole lot of new genes that we've identified. And last week we were in San Antonio for our breast cancer meetings, and I think there was a slide that one of the epidemiology people from the Mayo Clinic did. The more patients you have in these studies, the more robust our understanding is. But it was, in some cases, it was 17% of women with breast cancer actually had one of these genes that predisposed them to get cancer. So getting back to, gosh, I wish it was as easy as a virus. It probably isn't. I mean, there may be something, you may have a genetic predisposition and then something else happens, but right now genetics is probably a pretty important part of breast cancer. Yeah.
That was actually going to be my next question. So there was a lot of talk about liquid biopsies and genetic testing in San Antonio. And can you just explain the differences between, let's say, Foundation 1 and Garden 360 and genetic tests versus the liquid biopsies? And should patients now, I've had the Foundation 1, but should now be looking into the liquid biopsies or whatever you call it, cell-free DNA?
Right. So when we talk about doing genetic testing, this is not about what mom and dad gave to you again. This is what your cancer's genes look like. And as cancers get treated, they mutate, they change their character. And so we may sometimes identify that certain genes in that cancer, as it grows, as it's treated and changed along the way, we may identify drugs that are likely to be active against them. There are a whole variety of companies that have been that sprung up trying to do gene sequencing, so looking at your cancer and what are the genes that make up your cancer. And they're really kind of, they're enlightening. They may not always help the patient. We may not always find an abnormality. So for example, in lobular breast cancer, we look to find HER2 activating mutations. So even though your cancer is HER2 negative, sometimes a cancer will actually have these mutations that actually stimulate HER2, even though what we measure in the lab is not HER2 positive. And yet, women with this turn out to benefit from HER2 drugs. So these tests are really very helpful. So you can either test the tumor on the cancer itself, or those cancers shed these abnormalities in the blood, and you can measure them on the blood, which is the liquid biopsy.
So which is it the Guardant, or is it Foundation 1? I heard has one now.
Yeah, Foundation 1, Foundation 1 also has a liquid biopsy as well.
And they're all the same?
They probably are all the same. What happens is, as time goes on, there are more and more mutations that they look for, more and more genes they look for, and as we get more knowledge, because we're talking about thousands and thousands of genes. Is it the gene? Is it the combination of genes? So, there's certain genes that we can use that will predict that somebody's going to benefit from Ibrance. And there are certain genes that we identify that means you're never going to respond to a hormonal therapy. So these are helpful in directing therapy, but we haven't totally realized their full potential.
And will insurance pay for
So does insurance pay for it? Insurance is starting to pay for it more and more. The companies like Foundation One, usually they sort of cut a deal and they never charge you for the
It happened with
test.
the other one, but I don't know about the liquid one.
Yeah. But more and more insurance companies really are paying for them because they really are important. They're important because you want to give the right drug to the right patient. And giving drugs that aren't effective cost insurance companies too. So I think they've sort of come to realize that these tests can be helpful, not only at identifying drugs that will help you, but keeping you from getting drugs that aren't going to help you.
On the subject of liquid biopsies, can they be used as a measuring
I'll tell you how much
component
cancer there is.
for bone metastases? Because there are certain trials that I have not qualified for because they can't measure the bone metastases. However, I've always been curious if liquid biopsies can be used as a gauge.
Yeah, so liquid biopsies basically tell you what the cancer looks like genetically. The problem, we always get back to this problem with bone-only disease, and for those of you folks who've tried to go on a clinical trial, you know, what we call evaluable cancer is cancer in the bone. It's there, we know it's there, it gets better, it gets worse, hopefully it gets better. And then there's measurable disease, and measurable disease is you got a lump in your liver this big and we can measure it. And unfortunately, you know, the pharmaceutical industry wants to know for sure that their drug is or is not working. And so usually they make it a requirement that you have measurable disease, something that you can actually see on an x-ray, that you can say this is 2 centimeters by 3 centimeters, and that it shrinks to 1 centimeter when you give treatment. And so unfortunately that's, unfortunately,
So the liquid biopsies are
does not help us. So
It's a problem with Lobular too, very,
Yeah.
very
Of
big
course.
problem.
Of course. Yeah. And
yeah.
sorry, I don't mean to, sorry, I hope it's helpful for everybody.
Yes, good.
Can you ever raise your white blood count naturally, like how you raise your red blood count when it's dropping?
Can you raise your white count? So to a certain extent you can. Your white cells are sort of on the lining of your cells. You can exercise before you get your blood count, and they kind of come off the walls of your blood vessels, but they have to kind of come on their own, or with drugs, it's the growth factors like Neulasta.
But what can you raise how can you raise it when it's dropping from the eyebrows?
Yeah, so actually, how you raise your white count after Ibrance is pretty hard to know the answer to. Because it's the weird thing about Ibrance is we drop people's white counts pretty darn low, and people never get infected. So, you know, your white cells help you to fight bacteria and viruses, and we worry most about the white cells, the granulocytes of bacteria. But we get your blood counts really low with these drugs, and yet it doesn't, you don't get infected. So we modify the doses, yes, by that, but it doesn't put you in danger of anything. So there isn't anything to do.
You're extremely tired. So how can you raise it for you not to be tired?
It's not the white cells that are making you tired, though.
With what? Just the
It's
medication?
I think it's the medication. You know, I mean, people can have normal blood counts when they're on chemotherapy and feel awful. Those drugs don't only attack, you know, they attack many tissues in the body, and you know, why you get fatigued, we're not totally understanding of it. Presumably it's because those drugs are affecting other tissues as well.
How do you feel about ribociclib and abemaciclib as compared to Ibrance?
So the question is, so there are these drugs, the Ibrance that's going to reset your new you on television, versus ribociclib is a drug you take that twice a day, same sort of schedule, 21 days on, 1 day off, versus abemaciclib, which is the third one of these drugs that you take continuously twice a day. So abemaciclib is probably the one of the 3 drugs that is different than the other 2. The other 2 are pretty much the same. Ibrance is easier to use because we don't have to check an EKG or anything like that. So we use Ibrance probably preferentially because it's easier for you and for us. We're not constantly trying to look at an EKG, which you need before ribociclib. But abemaciclib is a different drug. It has diarrhea as its major side effect, whereas the other 2 drugs cause low blood counts. And abemaciclib actually seems to penetrate the brain, which can be beneficial, especially in lobular breast cancers and people who actually have spread to their brain. We see responses in the brain to abemaciclib. So, you know, usually it's sort of preference, but there is no head-to-head comparison of those 3 drugs with hormone therapy. We use Ibrance most because I think it was the first one on the market. It's the easiest one to dose and the one we know the most about.
I have one.
Okay. One more here.
Your thoughts on, okay, so I am that unfortunate patient that has anaphylactic reaction to Herceptin, imagine that. So I've not been able to take Herceptin since the first diagnosis. And what are your thoughts on Herceptin desensitization? Does it work? Is it something UCLA is doing? Is this something that you believe is effective?
You know, I have no idea about. I've never had anybody anaphylax on Herceptin, so I'm afraid I have no answer about that. I don't even know anybody who's ever desensitized somebody.
Yeah.
I'm sorry.
I know.
Yeah. Yes, ma'am.
Is there any new information on the CHEK2 gene?
So CHEK2 gene. So yes. So when I said earlier about CHEK2 is one of the many sorts of genes that help to repair tissues when they divide and die and so on, keep them on the straight and narrow. So as time goes on, there are just a whole host of genes that we've now identified are associated with an increased risk for certain cancers. CHEK2 is one of those, PALB2 is another one, RAD50. And how much it increases your risk, we're just sort of coming to grips with, because now that as you identify families who have lots of cancer in their family, you know there has to be a genetic change there, and we may not have found it yet, but CHEK2 is one of the genes that's associated with an increased risk for breast cancer. We don't have a target for CHEK2, but there are a whole group of drugs that we use for BRCA1 and 2 mutations, olaparib, and those drugs have also been shown to be effective in women who have PALB2 and CHEK2 mutations. So insurance doesn't like to approve them for those reasons, but they are effective, and we tough it out with them in those cases. Guys, thank you much for your questions.
Thank you.
Thank you.